Good morning, ladies and gentlemen. So I'm going to try to cover the topic of percutaneous biopsy and to answer to the questions that has been asked by the organizer. First of all, who is concerned by percutaneous biopsy of the lung in the setting of lung cancer? I think that the main thing, first of all, is to emphasize the role of the multidisciplinary meeting in giving the proper indication for a patient. Whatever it would be in the perspective of the source of the treatment or for the purpose of diagnosis of staging, the multidisciplinary meeting with the presence of a radiologist, of course, a pneumologist, but also an oncologist, a radiation oncologist, the surgeon is certainly the place where the indication should be given. And the current indications are the inoperable patient for spread of safety reasons, the distinction between primary and secondary tumors, the absence of response after a first-line treatment, which is a little bit new indication, and there is still debate indication, whatever preoperative biopsy for a suspected T1 N0M0 lesion should be operated on, or biopsy is discussed and is depending on even of the patient will. And nodules associated with hypermetabolic nodes are also likely to be biopsied under mediastinoscopy or endoscopic ultrasound-guided biopsy rather than biopsies of pulmonary nodules. There is an important question which will rise up when we consider the nodule and the biopsy of a nodule. You see, it is the classification of adenocarcinoma that has been revised in 2011, and the correspondence, the correlation between the three categories of nodules that are today described, the non-solid, the partly solid, and the solid nodule. And considering this, it is very important for the pathologist to be able to give a proper diagnosis, even for therapeutic point of view, because some micro-invasive adenocarcinoma, which have a very good prognosis, could be operated on by segmentectomy rather than by lobectomy. So to provide such an important diagnosis, we should use the most appropriate technique to get histology. And this question has been asked to a group of experts by the Journal of Thoracic Imaging, and their response was unequivocally that despite the good results that could be obtained in terms of diagnosis of malignancy in a non-solid or partly solid nodule, the biopsy, the percutaneous biopsy, may compromise the ability to separate the different categories, doesn't provide adequate architectural detail for concluding to malignancy or not, and these biopsies should be restricted to lesions with large solid component, and this is our current way of doing things in my institution. The second thing is to consider the relative contraindications. All contraindications in percutaneous biopsy are relative, and one of the most important is certainly uncooperative patient, whatever they have an altered mental status or intractable cough. But a severe respiratory compromise, and including the unique lung, is not an absolute contraindication and should be discussed. Of course, with the if IV1, despite there is no real threshold, but the most important thing is that an experimental radiologist will perform the biopsy, that the patient should be able to hold his breath for a few seconds, that the chest tube should be ready, and intensive care unit should be used for follow-up the patient. And it's the same for coagulation abnormalities. They usually postpone the biopsy, but are not real contraindication. It is sometimes difficult to stop antiplatelet therapy because a recent coronary stent has been put, but the biopsy could be postponed, and same for the Plavix treatment, which has to be withheld for 5 days. The pulmonary hypertension is a classical contraindication, but there is no real screening for pulmonary hypertension before a biopsy. It is also something very relative. And of course, there are contraindications that are due to the local conditions, the localization of the lesion. Now we should consider for some patients those that are likely to get a pneumothorax and sometimes a tension pneumothorax, and that can be very severe, for giving a good indication. And there is a very large result in the literature concerning the factor associated with pneumothorax. And from the beginning, we know that the COPD is a definitive factor, but there are also the lack of history of ipsilateral surgery, some lesion characteristics, that's the depth of the lesion, the length of the needle track, the size of the lesion, and some technical characteristics such increased outer diameter of the needle and so on. And I think one of the most important is the duration of the procedure, but it's not always and often said in the paper, because most of the paper and in most of the published results, biopsies are done by experts. Most important is a factor associated with chest tube placement, and again, a lot of results in the literature, and the last one from this retrospective over 9 years study, including more than 1,000 patients with CT fluoroscopy core needle-guided biopsy, showing that the pulmonary emphysema is certainly the most important factor with an odd ratios over than 3, and also, but with a much lower odd ratio, the greater lesion depth. So these results are from cohort and from population, but are we able to estimate the risk of a complication on an individual basis? Surprisingly, this issue has not so much been considered in the literature, and there is one paper showing that the disagreement between radiologists for predicting a pneumothorax is rather high, 55%, even if most of the patients with high risk of pneumothorax are properly estimated. And in our daily practice, I'm sure you have the same, we have seen some very surprising cases. There is no data in the literature considering the risk of hemorrhage, but this small nodule in an asymptomatic woman who was a secretary of my colleagues gave me the most threatening hemorrhage in more than 20 years of practice, and it was tuberculosis. And opposingly, no pneumothorax was observed despite the extended emphysema in this case. So it is extremely difficult to predict on an individual basis the risk of hemorrhage and pneumothorax. What about the choice of pulmonary biopsy versus other methods of diagnosis? Bronchoscopy. With bronchoscopy, a combination of sampling, washing, brushing can drive you to the diagnosis, but the accuracy of peripheral lesion or lesion less than 2 centimeters is extremely low. And probably one of the best findings on CT to predict the result of bronchoscopy is the presence of bronchus sign. Nevertheless, bronchoscopy is usually performed in order to detect other lesions that could be invisible in CT because they are flat in the bronchial tree. We can combine the utilization of transbronchial biopsy guided by CT, but there are exceptions. But this could be a good option decided in the multidisciplinary meeting if previous lesion has been biopsied and the result was negative, or if large pneumothorax has been the result of the failure of the biopsy. What about video-assisted thoracoscopic surgery? It's definitely a useful tool, despite it is much more invasive to diagnose pulmonary nodule. It's a very acceptable option when there are small nodules above the diaphragm, and depending on the habits of institution, the preoperative localization method can be used. We don't use it because the main condition for that is the vicinity between the radiology department and the operating room, and it's not the case in my institution, but many technique localization methods have been described. The second question is how to perform the biopsy. So there are pre-procedure checking guidelines that have been published, and most biopsies should be performed in a conscious patient, which is considered more or less as a biopsy partner, because it should understand, it should hold his breath during the insertion of the needle. The patient should be settled in a comfortable position, and we use fentanyl and local anesthesia during this biopsy. One of the most important things is, of course, to avoid the pleural extension of the needle, able to drive due to pneumothorax with the needle used for local anesthesia. What about the techniques for image guidance? Most of the biopsies are performed today using CT or using CT fluoroscopy, with the drawback of higher radiation dose for the patient and even for the physician for CT fluoroscopy. So effort should be given to reduce this radiation dose, but this is the most common and the most known technique in which that is used for guidance of biopsy. The cone beam imaging has been also described as a very useful technique. I have no experience in that, but all these techniques give access to central lesion, and this is a major point. The position of the patient is variable for biopsy, and biopsy can be done on prone or supine or lateral position. The most important thing is that the patient is fixed and comfortable on the CT table. Planning a trajectory should avoid as much as possible the aerated lung, of course, the chest vessel, especially those that can provide a very severe hemorrhage. And of course, the planning of the trajectory should avoid the fissure, belay as much as possible, and drive to the cavity wall, and it is still possible to perform a biopsy even in the presence of a pneumothorax, providing that the pneumothorax is in the same time as the biopsy aspired. It has been proposed to have the shortest way through the lung to go to the nodule, providing that the bronchi distal to the nodule are likely to be occluded and that the pneumothorax will be less likely to occur. There is no proof in the literature for this. And more importantly, I think, is to combine the pre-biopsy CT and the TEP to be sure that the biopsy will be performed in the right part of the lesion and not in the atelectasis. There are still lesions that are difficult to biopsy, those that are abutting the heart and are highly in the superior portion of the right middle lobe because of the presence of the fissure, in the deep costophrenic sulci, because the reproducibility of the respiration is low, and those that are small and providing that you can see that the vessels are not concerned by the biopsy tract, you can do some biopsy in a lesion present in the eyelid. The coaxial technique is considered today the basis of the lung biopsy because of a single pore puncture, because it's easy to reposition the needle, and then because of the prevention of air leakage. But care must be given to the distance between the distal port of the cannula and the distal port of the needle, and this is why it is in most cases necessary to insert the needle just at the periphery of the nodule. The correction of the needle course is something very easy to done, and how many sampling should be needed has been relatively poorly evaluated in the literature, and there is one paper that have shown that the sensitivity is increasing with the number of needle paths, with up to 3 needle paths. With more than 3 needle paths, there is no need for, there is no increased sensitivity. As much as possible, it is important to try to sample the various parts of the lesion, but it's not always possible. What we should do, histology or cytology, is something has been largely discussed also, but most of the time today in the setting of lung cancer, the cutting needle are used. And there are two categories of cutting needle. Those are giving you half of a cylinder, and those are giving you a complete cylinder of the lesion, which is, in my opinion, more suitable. But there is no real comparison in literature available. And you can check by visual inspection the groove of the needle that the sample is correct, and also check after the needle file that there is a shock wave or a small haemorrhage distal to the needle, to the nodule, which shows you that the nodule has been traversed by the needle. Whether fine needle aspiration should be done in addition or instead of cutting needle remains something debatable, but in this case, I think we should have a pathologist on site to provide an extrapercutaneous examination of the slides. This is not the case. We tend, and this is more and more the case for most of the publication, we tend to use cutting needles. The reason is that we now need a molecular typing. This is an example of the search of mutation of the exon 19 EGFR gene in a patient. And this example is here to show you that the pathologist will select a part of the specimen in order to provide the molecular typing. And an important result is not only that there is a microdeletion here in this case, but that this was based on less than 5% of tumoral cells. This is okay because the result is positive. This is why the sequential technique using PCR is extremely sensitive. But if the result was negative, this result should be considered with caution. So the proportion of tumoral cell using to provide molecular typing is something very important to consider. Now, considering the post-biopsy care of the patient, is settled in a dependent position, despite it has not been proved really that it's very efficient, and of course vital sign monitoring and positional precaution. And the patient is followed up by immediate CT slice to see if there is pneumothorax and a shell film at least 1 hour after the biopsy, and can be discharged. Patient can be discharged as an outpatient or 24 hours, depending on the habit of the hospital. We can treat pneumothorax immediately if it occurs during the biopsy by simple aspiration done by a needle inserted, another needle inserted in the thorax. And if the pneumothorax increases, the chest tube placement is necessary using usually a small bore catheter is sufficient. Whether the prevention of pneumothorax can be obtained by the blood patch or the installation of saline has been evaluated, but we don't use any of this technique, despite it has been recently described and reported that the rate of chest tube placement was reduced by using this blood patch technique, which is a kind of sealing of the pleura. Blood of the patient is try to seal. We try to seal with blood of the patient the pleura using the external cannula. The installation of saline in the outer cannula has also been proposed in one paper, and we have done with two-center prospective randomized studies that we have not published so far, and we didn't see any difference in the number of pneumothorax and chest tube placement between the two arms. Therefore, we don't use any of this technique. The last question that I've been asked is why a percutaneous CT biopsy is employed. And there are two reasons for that, very simple. First of all, because it is a very efficient technique. And the second reason is because the rate of complication remains acceptable. The accuracy of the diagnosis of malignancy using percutaneous biopsy has been before the 2000s reported with sensitivities between 80 and 90, and the specificity was almost perfect. There are very few false positive cases after a percutaneous biopsy for the diagnosis of malignancy. And before the 2000s, the results obtained by core biopsy were relatively similar to fine needle respiration, considering the diagnosis of malignancy. And the main advantage of core biopsy was for the diagnosis of the specific diagnosis of benignity, which was much better provided by core biopsies. But nowadays, and based on 4 large studies that have been published so far, including each of them more than 600 to 8,000 patients, sensitivity of the biopsy is clearly more than 90%, but it remains with the same specificity, almost 100%, but it remains a negative predictive value of less than 90%, which is an important thing to consider, because this means that a negative biopsy cannot be, as a rule of thumb, for a clear benignity, and should be cautioned with that. The core biopsy is now favored over the fine needle aspiration, clearly in the new publication. And the factor of inaccuracy is also something that has been extensively evaluated in the literature. And the small size lesion is one of the most important factors. The accuracy of a lesion less than 1 centimeter is shown to be less than 70% in 2 recent papers. The exception is this paper. And this study, which is a very large study, was conducted under CT fluoroscopy guidance, which the author advocate to be the reason of this particularly good result. Opposingly, for very large lesion, the results can also be false negative due to the presence of necrosis. And it is important to focus on the part of the lesion which is not necrotic, which is not always visible on the CT imaging. This is an example of a small adenocarcinoma which was entirely necrotic, and the biopsy was negative. And it's sometimes very difficult to see, especially when the lesion is small. You don't see the central part if, of course, if the whole nodule is entirely necrotic. Considering now the subpleural lesion less than 2 centimeters, a very long pass has been shown to provide a better accuracy than the short pass in a recent publication. So long pass are probably better for small nodule for technical reason, but this is not, it is intuitively considered for somebody who know how to perform the biopsy. An important point is to know whether a percutaneous biopsy is efficient for subtyping non-small cell lung cancer and to provide molecular typing. And based on historical data, we knew that there were about more than 20% of patients consider non-small cell cancer non-otherwise specified, in which we were not able to distinguish between adenocarcinoma and squamous cell carcinoma. But today, for the personalized treatment, we need from a biopsy obtain histological subtyping, immunohistochemistry staining, and molecular typing with EGFR mutation, KRAS, and ALK rearrangement for the most frequent molecular typing. So the question rise up is, do we obtain adequate tumor tissue from percutaneous biopsy? The answer is clearly yes. The percutaneous biopsy is clearly efficient, and in this recent paper, more than 90% of the non-small cell carcinoma can get the specific subtyping using a percutaneous biopsy, and the vast majority, and even more, were eligible for EGFR mutation testing. And the paper of Ferretti and colleagues in lung cancer has recently compared 2 series of core biopsy of adenocarcinoma before and after the publication of the ATS-ESR ILSLSC guidelines, and they show that the number of biopsy adequate for molecular testing have increased, which shows that the ability of the group of the radiologist, pathologist, and molecular biologist to provide a useful diagnosis increase with time, from the time of this important paper has been published. Providing that we use core biopsy, even it's possible to obtain with fine needle respiration using needle rinse cell blocks, providing that we use core biopsy, which gives you a much more important volume of tumor cells, at least 3 samples, and the longest specimen as possible, we can expect good result. So the last thing is to consider the complication rates and factor. Everybody knows that they are mostly pneumothorax and haemorrhage. Tumor seeding is extremely rare, only seen in mesothelioma and thymoma. And the most threatened are certainly embolism. But the important thing is that in this large survey from Japan of more than 10,000 people, we have still deaths due to lung biopsy. So the rate of pneumothorax vary largely in the literature from one study to another. Their management is no, small are conservative, and the large symptomatic are need percutaneous salt-bore catheter. The complication could also be hemorrhage, with the various incidents which probably varies if you consider the hemoptysis or simply the alveolar opacities. The occurrence of pneumothorax is extremely rare. And the risk factors that have been suggested in the literature are the small-sized lesions, the great lesion depths, the long biopsy path, and pulmonary hypertension. But we certainly miss data from prospective study. One of the most threatened complications is certainly air embolism, in which the mechanism of cough include. Cough should strive to stop immediately the biopsy, and it suggests that it is due to the tip of the needle which is placed inadvertently in the vein or a small bronchovein fistula. And there are some risk factors that have been suggested, but fortunately the number of cases is extremely rare. This is a very threatened complication. The patient experience arrhythmia, myocardial infarction, seizure deficit, and die very often. This is the only case I've seen in my life. It was this year. And the diagnosis, because this is a rare complication, the diagnosis is clearly done if you take the time, once the patient has been resuscitated, to perform a CT of the chest and a CT of the brain, which show you the presence of air within the left ventricle here and the heart. Finally, there have been guidelines that have been published for percutaneous biopsy, and these guidelines are still very useful, I think, in order for the operator also to audit their own practice in terms of morbidity and mortality and accuracy, which is a recommendation, an important recommendation. But we should emphasize that, and this is a comment from the people that have been the writer of these guidelines, that guidelines are only good as the evidence they are based upon. And today it's clear that we are missing grade A and B evidence to support these guidelines. Thank you for your attention.